And it's really it's really a privilege and honor to be chosen to lead off this year's Grand Round series. So it's my pleasure to be here. Hopefully, we'll give you some food for thought as I progress in my presentation. So to start, Art mentioned kind of my scholarship. I want to kind of give you a sense of how I want to bring some things together. That my life as an academician has been doing research and scholarship at the intersection of the Islamic tradition, biomedicine, and Muslim practices. And that work involves empirical, textual, as well as theological lines of inquiry. Particularly, I look at how patients' religion, in this case, Muslim Americans, how their religious values and beliefs and identity influence their decisions and healthcare behaviors, how Islam informs the bioethical attitudes and practices of Muslim physicians in the United States, and then at a higher level, in a certain sense, how Islam as a tradition, right, and as a body of knowledge is used to furnish moral guidance to both patients and providers, but also to policymakers in the Muslim world. So that's the kind of work I do, with the hope that we move from understanding Muslim behaviors, right, to more ethically balanced interventions, both in community settings where we can interact with healthcare decisions in a faithful way, but also in terms of in the hospital where we can accommodate various views of the good and the right within our policies. And some of that will come into play at the end of my talk today. So the first part of my talk is going to be about answering the question, what is death? I want to offer several different dimensions and definitions and lenses through which we can answer that question. And I'll offer that I think of it in a sense for our bioethical purposes as a sociological construct. And the second part of my talk is going to be about how Muslims respond to a biomedicalized death state, giving you some insight into Muslim community views and how clinicians deal with discourses over brain death, and then Islamic juridical views on brain death. So that's the normative piece here from the Islamic tradition. And in the end, we're going to end with trying to address this question about accommodating different notions of death in healthcare, whether we can and should have pluralistic policies, and how that might look at the bedside. And this is where I hope to engage with all you in the audience at the last part of the talk. So my claims and the resolution of the claims are the following, right? This is an ethics talk, so I should let those up front. I'll claim that death signifies many different things to people in society, that has various purposes, which generate diverse behaviors amongst its stakeholders, and thus it can have different criteria by which it is certified or ascertained. I'll make the claim that Muslim bioethical discourses exemplify broader disquiet within society around medicalized death, and that the Muslim discourse has multi-level critiques that sometimes offer, and scholars sometimes offer imprecise guidance when they're trying to engage with notions about medicalized dying, and that the resolution to this might be to align death purposes with specific criteria that will then promote ethical action, and that we can hold multiple constructs of death in creative tension within society, and that we can certainly allow for plurality at the bedside. So this is a slide courtesy of Dr. Siegler. I borrowed it from him and he allowed me to use it. But there are about 2.5 million deaths per year. So let's set the context of death and dying in the United States. 2.5 million deaths per year. As you can see here, about 2 million of them, the vast majority, 80%, are what he has termed anticipated and negotiated deaths, right? Which involve withholding or withdrawing life support. So by and large, there are conversations with many different stakeholders around that dying process. And the bioethical context for that conversation from the clinician and family view is that the borders between life and death are increasingly fuzzy, right? We as clinicians and patients and family members can think about how to intervene, withhold, withdraw, sedate, not sedate. And the question becomes, should we do so? And if we should do so, that's a question of practice and policy as well as law. On the other side, ethically, you can think about, well, if we should do something, then what is the best way to perform that action? And that question is a question of virtuous practice. And so this is the bioethical context within which these decisions are being made. At the bedside, right, in the hospital system, over 60% of deaths in the United States occur in the nursing homes, assisted care facilities, or in the hospital. So the majority of deaths in the United States, right, you have at least three groups of stakeholders: right? Clinicians, the patient, family, and their surrogates. I lump them together. And there may or may not be religious professionals who are at the bedside tending to the individual who might be passing from this life. And oftentimes those conversations and that dialogue has a lot of concepts that are rooted in different worldviews that come into conversation. I'll illustrate that in a moment. But I'll say that I think those three groups, if you think of it that way, are truly our strangers, right? In the sense that the vocabulary that they use, the values that they want to maximize, the way they think about things might be different. And in our diversifying society, more often than not, you might have people with different backgrounds that enter the conversation, not just different languages. So let me explain to you kind of what I mean by the strangers at the bedside. At the bedside, we have a lot of conversations that are replete with fact value fusions, right? So when we talk about withdrawal and withholding life support, there are terms used such as suffering and futility in that conversation, either by clinicians or ethicists, right? When we talk about terminal sedation and assisted dying, questions and notions of dignity come into play. Again, a term that can mean many different things to many different people. And in artificial nutrition hydration conversations, the same thing, suffering and futility. These are terms that are used within those ethical case consultations, or even when thinking about reasoning through the decision to withhold or withdraw artificial nutrition and hydration. And I would say that these fact value fusions are just that. There's a medical potential fact, right? And then there's a value attribution on top of that from different places, right? So we can talk about Wittgenstein's language game approach, but we are engaging in a conversation which has some boundary positions, some shared values, but often not shared values. Often, more often than not shared values. And that you can have some conversation, but that conversation might miss the mark, right? If we're not in the right language game, so to speak. This is, I think, exemplified by this idea of brain death, right? So we have the World Brain Death Project, which perhaps more appropriately should be termed death by neurological criteria. So, Ariane Lewis's book, I included a chapter here, but we take that term out of, right, not brain death, but death determination by neurological criteria. So it's more specific, but there's still controversy around that. And as we know, our own art is involved in the conversations around the to be revised Uniform Determination of Death Act. So the idea of brain death is a fact value fusion that can mean many different things and is oftentimes misunderstood by all of the stakeholders at the bedside. Moving away from brain death, let's just talk about death for a second, right? So I like this picture here, and I want to draw your attention to that there's 4 healthcare providers there looking at the body. And even amongst those 4 healthcare providers, they have different purposes by which they're going to look at the body that might be right in a dying state or is a dead state. So the first one there with the syringe is thinking about whether or not the patient is living or are they dead, because they want to be able to administer some morphine to relieve the pain, right, the pangs of death. The second physician there is looking at the chest rise to see whether or not there is respiration, because one of the signs of someone passing might be that respiration ceases. The other physician there, right, in the garb of a surgeon, is a surgeon thinking about, well, what if death has been declared, right, and this person is an organ donor, can we take the individual to the operating room? If I were to slice into this body, would I be doing so ethically or not? And the fourth individual there is thinking about, has the death pronouncement been made? Death isn't real until someone says death occurred. There's a time of death. So with the clipboard looking at, well, who's going to say time of death so I can put in the record so the patient actually has died? That pronouncement is what becomes a reality for death occurring. So even in the biomedical space at the bedside, there might be different purposes and lenses through which you look at the passing of an individual. A religious scholar might believe, looking at the same picture, that death means that the soul has left the body, right? But for that scholar, the idea, or that religious support, spiritual support person, the idea of death occurring is not something that they adjudicate themselves. Someone has pronounced it, and then death has occurred. So they're not looking at whether there are signs of the soul departing the body, right, at the bedside. And then families often, for them, death occurs, might have occurred at some point, but death behaviors occur when someone is pronounced, right, that death in the hospital setting. So if you were, from a different planet, an intelligent alien, so to speak, right? I'm not going to talk about what's going on in Mexico and Congress these days, but nonetheless, if you're an intelligent alien, perhaps you would think about what is death for humans on the globe, and you would probe it scientifically with various different methods. You might think about, in biomedicine, well, there's this clinical notion of death, right? What are the criteria at which death is certified or ascertained, right? And that might give you some insight into what death is. Or from a biological register, what is a difference, right, between a body that is declared dead and not the one that's not declared? Or is there functionality differences there? Or from a bioethical register in biomedicine, right? How are duties owed different, right? What are policies and laws, perhaps, or behaviors that individuals do when there's a dead person and non-dead person? So in the biomedical domain, you might have different gazes that you upon different lenses through which you gaze upon death. In human behaviors outside of the healthcare system, you might think about, well, what are the rituals that various communities engage in when someone is dying or has died? What's the language that they use, or what does that signify? And then, is there a difference between how individuals treat dead and non-dead individuals? That would give you another empirical sociological lens through which you would think about what death is, right? And then in law, right? So what is death a legal cause for? What are the rights owed to dead individuals versus those who are not dead? So if you're going to do a study of death, right, in the human experience, you might look at various different ways on which to get a greater conceptualization of what death means. And my argument here is that humans imbue death with meaning, right? That yes, there is a metaphysical reality, but we are at a distance from that metaphysical reality. And for us to operate in societies, perhaps it might be okay for us to think about death as a sociological construct, right? And the signification of death is with the symbols, the language, and the behaviors that occur around that event. I mean, right? That instance of death. That we construct a reality in a society. That's what we're doing. So yes, I believe, and there is a metaphysical reality of death, but we are at a distance from it. And to operate, might be one way to do that. It's not my idea that others have said this as well. But what I would offer is that we have to think about death purposes. What's the purpose for death? What functional purpose it has in this instance to adjudicate there is death, and then you align appropriate criteria to certify or adjudicate that death has occurred. And then you can have ethical action and behaviors after that point. So the purposes align with criteria that lead to behaviors. Back to that troublesome concept of brain death, right? So what are the purposes of brain death? Well, for clinicians, it might mark the end of a duty to restore health or to preserve life, right? And that the certification of brain death, right, addresses moral duties owed to around withdrawal and withholding life support in the face of biologically, right, biomedically, clinical or physiological effectiveness of any interventions that we are able to offer. For families, noting that someone is brain dead might provide them with a chance for meaning making, right, in the face of a tragedy of the death of a loved one, right, through organ donation. And for the individual themselves, the same thing, right? Perhaps that if when they're declared dead, organ procurement can save or enhance the life of another individual, and that might be a value that someone wants to maximize, right, when they've passed from this life. So that's death, brain death, fact value fusion. I want to now move towards talking about Muslim discourses around this entity as a way to think about, right, pluralistic policies. So first, from an empirical lens, this is from a national survey I conducted that was funded by the John Templeton Foundation and sponsored by Islamic Medical Association of North America several years ago. We asked Muslim physicians nationally what they thought about death, right? Different views about definitions of death. And so you'll see here, right, amongst the physician populace, these are all Muslim clinicians, about half, right, felt that brain death and cardiac death are not the same state, right? They strongly disagreed. Half agreed. And then when we asked them whether this brain death entity signified a metaphysical reality, departure of a soul from the body, right? Again, about half. So the Muslim physician community in this case was split around how they thought the analogy was between brain death and cardiac death, brain death, and then the reality, which they held to, that departure of the soul is what is death metaphysically. When we did some modeling around the physicians, right, what are the characteristics of physicians who are more likely to feel that brain death is not death, brain death is not the departure of the soul of the body, or brain death is not the same as cardiac death? Those who are more religious are more likely to disagree with brain death on both registers. This is a smaller study, not of physicians, but of allied healthcare professionals. So this includes nurses and chaplains and others as well. What I want to call out for you from this study was that when we did the survey, we asked them about the choice, right? About whether or not a brain death exam should be performed at the bedside. And half of our sample, this is about 50 people, believe that families should be able to choose whether or not evaluation for death by neurological criteria is done. So they felt even if they agree, and in this survey, most people agreed that brain death was equivalent to legal death, they still wanted some choice, right, amongst that. Moving to the the normative sort of domain, traditionally, when people talk about Islamic bioethics, right, they think about Islamic bioethics as this, right? That is, generally, there's a question asked by a physician, oftentimes because a patient's asking the question, or they might have their own. And then that physician goes and seeks out a religious scholar, right? That might be in the academic setting or in the community setting. And that scholar then thinks about scriptural sources of Islamic law, right, or the objectives of Islamic law, some of the legal maxims, and issues a verdict, right, an edict, a fatwa, right, in the Arabic, about whether this action is permissible or not permissible, right, whether it's obligatory or forbidden. That many people think about Islamic bioethics as, in this case, Islamic law, as a fatwa finding exercise. I'm going to complicate that notion in a few slides, but let's stick with there for a moment. So we certainly have a lot of fatwas, religious edicts, on various aspects of medicine. We have moved beyond, in this case, there certainly are scholars who do this singularly, but you have juridical academies in many places around the world, where you have this idea of a collective body of religious scholars, some scientists, and other stakeholders. Sometimes it could be a policymaker, sometimes it could be a pharmaceutical company, depending on the issue at hand. And they all come together and they have conversation and dialogue around the ethical question that's being asked, right? The rationale for this is that diverse experts, right, will overcome individual gaps in knowledge. So you might have scholars from different legal traditions, right? Or you have scientists from different backgrounds, epidemiologists and social scientists. And that group deliberation can bring different religious perspectives into dialogue. And therefore that the output of this academy might be much more applicable, right? And be much more nuanced than that of a single jurist doing it alone. And there are many examples, as I said, of these sorts of councils there in the Muslim world, but also we have a Fiqh Council of North America, in the United States, where I'm one of their advisors. So let's look at what these academies have put out in terms of brain death. Now, before I share with you some specific rulings, I want to give you a sense of the larger debate, right? So I want a caricature of two scholars talking about a little bit of what they thought about brain death. So there are two Grand Muftis of Egypt who are involved in various conversations around brain death in Egypt, of the same background, right? They were not Grand Muftis at the same time. They can only be one, but they were successively Grand Muftis in Egypt. So one, Sheikh Tantawi, felt that death, the occurrence of death, is a medical affair. He almost abdicated, said, look, the physicians have to tell us what this entity means. And if they think that it's death, then it might be death because they're the ones who are versed in what signs of the body occur when someone dies. On the other hand, Sheikh Ali al-Jum'a, he felt this was not the case, that it is not about a medical technical issue, rather it's about uncovering the truth about something, right? Uncovering the metaphysical physical reality that might have signs within the body. And so therefore, religious scholars must be involved. You can't abdicate your ethical sort of duty to just physicians, and they tell you rather we must be involved in what they're doing and thinking about that. So different views from the same country with individuals of the same caliber, right, in the credentials. So that synopsizes what happens across the Muslim world. This is a dated paper now, several years ago, but nonetheless, you can see that there's a lot of plurality here within the Muslim world, right? Even there's a council here in the United Kingdom that some scholarly bodies said brain death is equivalent to legal death, meets the threshold in Islam, and some said no. But they were foregrounding a purpose, right? So brain death was endorsed for the purposes of organ donation, or the question was asked about withdrawal life support. So there was always a question, a context, a purpose for that adjudication of whether brain death satisfies Islamic ethics or not. So let me share with you a couple of these examples. These are the ones I often teach about because I think they signify the diversity within the Islamic tradition, but also give us some pause on how they think about these things. As I said, sometimes the guidance might be imprecise when you think about it from the level of a clinician who has to practice at the bedside. So this is the Organization of Islamic Conferences, the Islamic Fiqh Academy there, right? They said that brain death meets the threshold for death in Islam. They said clinicians are the experts, right, in assessing death, kind of like what Sheikh Tantawi did. And this is the English translation of their Arabic, but all vital functions, their notion of brain death was all vital functions of the brain cease irreversibly, and the brain has started to degenerate, right? And those bolded and italicized terms are because I think each of those terms can bring about some questions like, of practice at the bedside, right? So what are the vital functions of the brain? Didn't discuss that. What does it mean to be irreversible? We know have this conversation, cessation and reversibility. Didn't address that. and no protocol looks at the brain to see whether it degenerates, right? So, like, no one looks at tissue. So when you apply that at the bedside and you think this might, someone might say, well, this statement exactly is the religious edict, then you might have a question, well, how do I do this in terms of protocols, in terms of criteria? The IOMS, the Islamic Organization of Medical Science in Kuwait, said that brain death is a state of unstable life, right? So it's a dying state. And there's a specific term in Arabic for this type of life that's not fixed, right? Hayat ghayra mustaqira is the Arabic term. So in their view, and this council interestingly had scholars, some of the same scholars at both meetings, and they occurred within several years of each other. But they said that medical knowledge is not certain, right? This is our claim, that it's probabilistic, and it is largely divorced from metaphysical reality. So if you're trying to uncover the truth of the metaphysical reality, we can't just rely and hang our hats on medical science and what clinicians say. So they determined that if a person has reached, and they were very specific, brainstem death, because they clinicians had told them what that looked like brainstem exams. Some of the rulings of unstable life apply, meaning that this domain of unstable life in Islamic law can be applied, but some of them, and specifically, one can withdraw life support that's permitted, but organ donation and declaration of death is not. That can only occur when after cardiopulmonary cessation. This was their view, and these views are operative in the Muslim world. So if you're going to look at this literature, right, this is the fatwa sort of literature, and you're not conversant fully with the terms, you might find that some of these terms I don't know what they mean. And oftentimes clinicians or chaplains or even Muslim patients and their families pick up this literature and they are confused at what are the terms being used, what does this sort of mean. And I would say for the bedside purposes, oftentimes the literature does miss the mark. As I mentioned to you, what does it mean to be irreversible? What does it mean, oh, some vital signs? What's the definition of that? There might be imprecise or incomplete guidance. And this is because, right, if you think about Islamic bioethics, right, I'm talking about the literature, not just fatwas, but the bioethical literature at large, there are contentions around what the Islamic is, right? So what are the sources of normativity within Islamic tradition? There's a debate around that from various corners that shows up in the literature when you look at it. Or what are the methods of researching or deriving these moral rules? Similarly, there's a debate around what is bioethics, right? Or what is an Islamic version of bioethics would look like? What's the scope of concern from the Muslim tradition? Are we just importing things from quote unquote the West, and now that's what we are worried about? Or is there something indigenous that we should be worried about as Muslims? And then what's the relation to the field of bioethics at large, right? Academic bioethics, as we know, some rarely admits religious perspectives. And so this is also a debate of whether or not Islamic bioethics literature should think about that or not, right? Should we, in this word, code switch, so it's not as religiously laden with scriptural language. So as someone who's been thinking about this field for a long time, this is my definition of Islamic bioethics, right? It's a discourse. And it's a discourse that uses Islamic tradition to address moral questions and ethical issues that arise out of biomedical sciences and the allied health practices. That it involves oftentimes that discourse, right? It involves a dialogue between the medical field and an Islamic authority. Oftentimes the individual representing the medical field is clinicians or groups of clinicians. And Islamic scholars trained in seminaries are the Islamic authorities. But around that discourse, and sometimes participating in a discourse, are various scientists, right? And these are termed broadly, social scientists, right? It could be, empirical scientists that help inform the question, right? And then they help inform why the question is phrased in a certain way. And sometimes they might study the dialogue that occurs. That this scientist was very important as well to understand the ethical problem space and certainly to generate the solution. So what is Islamic? I told you there's some contentions around that of Islamic bioethical discourse. Well, for one, it's ties to the scriptural sources and the bearers of tradition. I mentioned to you that oftentimes it's seminarians who are the Islamic authorities, right? Because they are the ones who are tied to revelation, and they are the ones who are the interpreters of revelation. They study, they get degrees in that, and they're the ones who actually have authority when someone's seeking guidance. They go to these scholars for fatwas. But ideally, for an Islamic bioethics, not just Islamic law, you have to draw upon different sources of morality within the tradition. So theology and philosophy helps us understand, right, the product, the end goal, right? You think about legal ethics, I talked about a lot of fatwas, and that's fiqh, right? So that thinks about the moral status of the action, and that helps us ascertain and analyze the moral status of the action. But then there's also practical ethics or character and virtue ethics. These are terms that don't exactly fit the Arabic, but nonetheless, right, this is agent focused, right? So you have to think about the agent, their intentions, their character formation, then the action that the agent does, and then what the action will produce. You have to bring these three sources together to actually say this is what an Islamic bioethical view might be. That would be my argument. And so you see this in a figure here, right? That we draw upon the moral machinery of Islam, Islamic law, theology, right, and practical ethics. That's the moral machinery that helps us think about the Islamic, but we have to then put that into conversation with what's occurring in clinical practice and what's occurring in health policy. Oftentimes, those are the domains where the ethical problem space resides, right? And then we bring that into conversation with the social, biomedical, and contemporary philosophy and science. Other sciences help inform what is the full conceptualization of the problem space so that we can get into the solution space. So that's a little bit of an excursion to Islamic bioethics and juridical views. I want to kind of now talk about back to the question of death. So as I mentioned, death purposes, death criteria should be aligned. Well, what are the purposes of brain death? Right? I mentioned this previously, but it's kind of helping us think about it in a focused way. For clinicians, it's a bioethical endpoint, right? And it's also a physiological endpoint. Bioethical endpoint, duties are discharged. Physiological endpoint, right? There is quote unquote futility for interventions at that stage. For families, it's a meaning-making opportunity, oftentimes tied to organ donation. But it's also ethical endpoint for them that the rights, the duties, right, owed to this individual from my family are going to be discharged and will end. Right? If those are the purposes, then the question becomes, what are the deliverables upon which the criteria for death can be furnished? Well, if there's a biomedical purpose around organ donation, then biomedical data can tell you what are the best practices for organ procurement that would benefit the most lives, if that's the outcome, right, that one desires. At the clinical sciences will help you think about at the point at which clinical treatments, right, interventions are physiologically futile. And then social science will tell us what is the best idea of how different communities and cultures think about meaning making at this stage. What is that optimal in society? What is it optimal in this community for the community of practice? Those are the sciences upon which the deliverables, those are the sciences upon which can generate deliverables upon which the criteria for death can be furnished. Again, aligning purposes with criteria so that we can have ethical behaviors. Now, the truth claims in the biomedical register would be that prognosis is abysmal, right? That our duties are mostly discharged, but biomedicine by itself might not make any metaphysical claims about what that means beyond that, beyond prognosis and beyond bioethical duties of clinicians and others being discharged. So the appropriate critique, if one were to make a critique, would be that variability and errors in clinical diagnosis of the state, right, should be taken into account when we make policies. And if we're thinking about bioethics, well, what are the moral duties to the dead, right, and the nearly dead, let's just say, and how does that square up? Are we actually doing harming these individuals when we do certain things antecedent to the declaration of death? And that are the purposes for which brain death is created as an entity suspect, right? Is organ donation or withdrawal of life support or so on and so forth, are these things worthy for us to create or to instantiate this entity, right? You might make these critiques and they would be appropriate at those registers. What might be misdirected is thinking about ontological views of what brain death means. I would argue that no metaphysical claims being made. And you'll find this also in the literature, particularly in the religious literature from various corners, where there are ontological questions around how medicine operates around brain death. So the solution might be that we think about different purposes, right? And that those different purposes lead to different criteria. And therefore, within any society, there might be multiple death constructs that operate. And religion, right, has something to say about the morality of action, right? But perhaps not necessarily in a pluralistic society, the labeling of the clinical entity. I'm not saying they separate. I'm just saying that, but it critiques the purposes, critiques the actions, perhaps not the clinical entity, right? And you'll see this take place in the Muslim world. So at one of those meetings, the OIC IFA meeting, Sheikh Ashqar mentioned the following as his right. So basically you end up like the Supreme Court, you have a majority opinion, and then you have different scholars who might write minority opinions or furnish their own views. So he said, brain death, his view is that brain death should allow for withdrawal of life support, right? But organ donation and disbursement of inheritance shouldn't happen when brain death is declared. he was holding in creative tension two different criteria: brain criteria, right, neurological criteria, and cardiopulmonary criteria. And he felt that after the second criteria are fulfilled, the cardiopulmonary, then you can have different aspects, different purposes play out, and different notions of death, right? Different constructs of death in this case. So, and this would be Islamically authorized, what his view was. So let me share with you a couple of stories about trying to have conversation in the Muslim world, um, and what happened. And so bringing this theory, this idea into practice. So in 2017, I think 2017, 2018, I was invited to be as part of a conversation in Qatar around brain death and death and dying in the Muslim world. This is a scholar, Sheikh Hamad Raisuni, who is the former president of this international body of Muslim scholars. He's a senior expert, has been participant in all those juridical councils in the Middle East that I've mentioned. And he was at that time, so we were in Qatar, he was a visiting professor at Qatar Faculty of Islamic Studies. So we had a conversation as part of, I think there were 15 individuals who were invited to be participating in this conversation, in this dialogue. And so I talked to him about this idea of death, right? That I don't, because everybody was concerned about brain death. What does it mean? What does it mean? What we should do? And I asked him, about what he thought, and then we had a dialogue. And at the end of the dialogue, he said, Aasim, and our English doesn't do the Arabic justice, but you guys are the people of problems, right? And you represent them, because medicine doesn't know what it's doing. It doesn't know what brain death is or isn't. There's papers here that people are critiquing left and right. Why do you expect me or us as scholars to be able to resolve the tension that resides within the name of medicine? You guys don't know what you're talking about. You bring problems to us and expect us to resolve it. That's not how this dialogue should work. And to have us now have two different ideas of death would cause a lot of commotion and disarray within our society. Okay. Several years later, this is actually last year, or now 2020, a year before that, 2021. So this is Sheikh Hanana Karusi. He is the Assistant Grand Mufti of Oman. Oman has been thinking about a brain death declaration in the context of organ donation for several years. They just had a law that was issued around both of these entities. And he's a scholar as well of repute. He's did his DPhil at Oxford University, but also trained traditionally. So he invited me in the middle of the pandemic. We were having dialogue at Omani time with these bodies who were thinking about these laws. And so I advocated, I said, well, they were really wanting to have organ donation society. Oman has different Islamic Muslim groups there. And I was pushing back. He said, well, we want to have organ donation policy. We want to have a single notion of death. And I said, well, can we have brain death for organ donation purposes and not brain death as death for other purposes, leading from what others had said in different scholars? Again, the question was, well, if we were to do that in our society, would it lead to confusion? That we are privileging biomedical purposes over what is a metaphysical reality that should be known universally by everybody. And in the end, they did have brain death for organ donation purposes and also for withdrawal life support, which was a bit different than what other scholars had said at that meeting. So again, trying to have different views of death working in Muslim societies might have posed a challenge for those who are leading these conversations. So back to the bedside before I conclude. I think that at the bedside, so I talked to you about policy, but at the bedside, we should have perhaps a different way of thinking of things, particularly for us who are ethics consultants, right? Who are trying to resolve a ethical problem at the moment of crisis for families and for individuals. That we should come into that conversation with cultural humility, with the notion of multipluralism, and toleration of inconvenience on the part of the healthcare team, right? That individuals, as one of my mentors said, right, the family lives on, right? Even though the individual might not. And that when we're at those moments of death and dying, or our patients are, we should think about us as the providers being able to tolerate more perhaps than that family that has to remain intact, and that the values have to be privileged in certain ways. So I would offer that we should discover, consider, and negotiate and accommodate. So what should we discover? We should discover the meanings and values attached to living and dying, right, at that state. What does it mean to be alive? What's the value they attribute to that? What about death? And what does that mean to you all, right? So discover that. Then we should consider our cultural norms, their cultural norms, and the professional constraints we have in our society about what sorts of things we can and cannot do, what is conventional might not be the best thing at all times. So we should consider those things and then negotiate and accommodate both the actions and the non-actions. In this case, I shared with you that one of our surveys said that they argued that there should be a conversation around doing the brain death exam, right? And then perhaps some scholars argue there should be consent around that, because that might mean in certain states in the United States that person declared dead. So we should negotiate and accommodate actions and non-actions on the part of the healthcare team to make that family whole and to make their values be privileged. So what would that look like? Well, what does it mean for life, right? What's the purpose and utility of life? Is it, and there are different views, right? Is it to perform good works for merit making for the afterlife? Is it about enjoying good experiences to have a quote unquote full life, right? Is it about righting the wrongs of previous generations and lives so that you have to then be reborn into another state, right? Because you've now moved up the register. Is it just to perform salvific acts? What is the purpose and the utility of life should be talked about when we have conversations. And then there are other views as well, like disconnection, disharmony, the hopes of an opposite later. That's relevant, our argue, to conversations about quality of life and goals of care. We often start with those terms as opposed to what does life mean and what's the purpose of that life, right? And then also obviously will have a relevance to the decision around, right, the manner and meaning of death. Valuations of life also have to think about rights and the respect accorded, right? Is there a right to non-interference and inviolability even for the dead body? Should we protect individuals in that state who are perhaps not conscious from vulnerability? And is there a certain way in which dignified or respectful treatment is manifested? That's relevant to conversations about organ donation. And we should have these conversations with those at the bedside, and whether or not brain dead individuals could be an incubator or host for fetuses. Lastly, the norms and constraints, right? This is around decision making. Are all families, or are some families, the locus of decision making? We privilege in our society individualized decision making. Sometimes that's not the case for those that we care of, right? Do we, as healthcare providers, are we supposed to primarily serve patient, family, or societal interests? What is that within your own notion of being the good doctor? We should talk about that when we engage in decision making and in conversation and negotiation with patients and families. And then, right, are we independent providers of goods, right? Is that all it is? You want an outcome, I can provide that good to get the outcome. That's relevant to decisional frames regarding shared decision-making processes between providers and patients and their families, and really the order of priority of decision makers within families. So my point is that once you do all that, then you can start having negotiation and accommodation of the actions and non-actions. Oftentimes, you don't have those conversations first. We think about the death decision first. And I'll argue that's not the best way to go about it. So with that, I think I'm right at time before we have some questions. I'd like to open up to questions around what I presented. Thank you for your time.
Hey, thank you, Aasim. Let me say right now, first of all, there's a lot of food for thought here and lots of really important insights that you're opening up to us. So much appreciated on that front. So if you'd like to ask Dr. Padela a question, please note in the chat, and you can certainly ask the question in the chat, or you're also welcome to let us know that you're in line and to ask the question. And we're actually going to go to Annie Friedrich, assistant professor of bioethics and medical humanities, and someone who Dr. Padela knows, with the first question for you. Aasim.
Yeah, well, thank you, Dr. Padela. Obviously, a great talk. And as you know from our work with medical students, I think it's always so important to be considering religious and spiritual dimensions in healthcare, which we don't, as you mentioned, we don't do that well or do that enough. This metaphysical component. I'm curious, I have a lot of takeaways, I think, but if you had to sum up like the one kernel, what can Islamic bioethics teach or bring to a more secular or contemporary or non-religious bioethics? Because I think so often people will throw up their hands and say, well, I don't work with Muslim patients, or I'm not Muslim, so this doesn't apply to me. And I think obviously some of the work you do of, we needed to discover, we need to consider, all of those are very important work. I think that as an ethics consultant, we tried to do that well. But yeah, is there something that you'd say this is actually a framework or a way of thinking, a way of being in the world that doesn't just you don't have to be a Muslim to resonate with it?
Well, certainly, there's several things I can say. The first, I'll say that if we think about bioethics and global bioethics, that religious and non-religious traditions need to be in conversation just to sharpen their ways of thinking sharpen their tools of analysis to really consider what that looks like globally, right? Medicine is globalized. I think the marginalization of certain voices and the privileging of others is a problem for that field, generally speaking. And I think that our orders of discourse are certainly privilege certain voices and not others, right? Even in the religious space, certain voices are privileged and others are not. So I understand. I'm just going to make that statement at first. I think we can't have a global bioethics without religious voices at the table, and certainly with a population of almost 2 billion Muslims should be at the table. But you didn't ask me that question. You asked me the question about what the one takeaway would be. As I have reflected on my career and thinking about, what Islamic bioethics might have to offer, though I contend there are different views on what Islamic bioethics might be. I think it's the idea of what we're producing in society, right? So how that conceptual fullness of what does health mean in society, and what is a social structure through which we can produce that health in society. I think we don't do that enough conceptually and theoretically in society. We just take there's a as Ray Javier says right there, they're interesting puzzles at the bedside, and we take those puzzles and we do puzzle fixing and puzzle making. We don't think about this larger question: are we producing health? Do we have a shared conception of health? Can in a society we have a shared conception of health? Then we can be purveyors of that health. Then we can create policies around the health. I don't think we do that, right? And I think that when you talk about Islamic bioethics, right, the nascent field, that the notion of the end goal to being produced in society is part and parcel of that, right? Although in a reactive state, obviously there's an issue of X, Y, Z to solve that from a fatwa basis. But I mentioned fatwas aren't all. Fatwas oftentimes don't think about that. So that's what I would say, that getting back to those concepts, right? Even the concept of what is the human being, what is health, what does a good life look like? All that sort of work, I think, can be done. And I think that conversation from an Islamic lens would enrich the conversations that exist in society. Hopefully that answers your question.
Yeah. The second question is from Garson Leader, Assistant Professor of Bioethics and Medical Humanities. And Aasim, Garson. Garson, go ahead, please.
Really interesting talk, Aasim. Thank you. Excuse me. Quick question. So you mentioned, your conversation with the gentleman in Oman and the concern about how society might handle the plurality of death concepts. And it's, so we see this in the broader debate over how to define death in the US, whether or not it's different religious-inspired views or just secular conceptual differences. And so one of the arguments against plurality, or taking a plurality view, it just is this. It'll lead to confusion at the bedside, but also in society, a lack of trust in medicine, potentially. And we have some test cases, like New Jersey being a state that has a religious opt-out carved in. But I wonder if you could say a bit more about what you think the concerns remaining are about a plurality of accepting the plurality of views.
I think you're very good. So I think we're very different. I think we're different societies, right? So if you think about, and I don't like the term developed or developing, right? Because doesn't mean economically developing, doesn't mean morally developing, but let's say those other societies, low and middle income, let's say, countries around the world where they're still struggling with how do we get some sense of essential goods that healthcare provide to our population, right? That is in rural areas or has a little access, or maybe they're indigent, they're poor. That's a different conversation than our high biomedical, technologically replete American. Even though people have issues here, we have disparities in access, but we have a very different society that, at least in the conversation, public conversation, people know what these sorts of things are, right? So when you're trying to introduce this idea that's already a little bit weird of organ donation and transplantation, then you say, now for that, we're going to change what death means in society. I think that was a real concern, right? And guess what? Who are the individuals who are going to write that policy? The Grand Muftis and that office, right? It's not some divorced state maker. It's the authority there becomes the authority by which I, as an individual, right, I'm saying this is a good to do, I mean, the organ donation, and this is what death means religiously. So they're tied together. So I certainly understood his concern, not about, yes, there was about multiple notions, but you understand that I am religiously validating, and we in a society that people are still coming to terms with, can I have access to healthcare, where this might seem a little bit odd at that moment. So that's that conversation there. I don't think religiously, as I shared with one scholar, you don't have to have a singular notion of the death construct operating in society. You can have death declared when, right, in certain purposes, as one of the scholars said, death declared in disbursement inheritance when cardiac cessation, and then brain death will allow for reanimation. So I think we could have been nuanced, but he wasn't willing to take that risk at that time to do that. I think in our society, let's move to our society. We already have, so, and I'll say the other thing, in Oman, we don't have many clinical ethicists at the bedside, right? They don't have that. Here, almost every hospital has to have people like you, Garson, right? Who do ethics case consults, who have time, right? Can have conversations potentially with family members, can bring some more nuanced conversations there. We already have states in the United States where there's different, right? As you just mentioned, New Jersey does something different than what California does, Illinois does something different, right? So we already have plurality within society. So I don't know if we need to have the uniform, right, determination of death act, but we can have the multiple determination of death act, right? Well, these purposes and this view, and when there are clear, challenges to a certain notion of death, we at the bedside and the clinical team can be nuanced. Okay, well, look, we're going to take your values as important ones and not impose ours over you. We talk about this in clinical ethics all the time, right? That's why autonomy, respect for autonomy came about. And we're going to do that, even in this instance when death is occurring. So own that, what we say, tell our students, own it. Own it at both the beginning and the end of life. And I'll tell you something else about the United States. We already do this for VIP patients. We already do it. If you're willing to pay, I'm sure you can get whatever you want and whatever notion of death you want in the United States. I can help you do that. So maybe that answers the question.
It does. Thank you.
Well, there's a challenge, which is if you are willing to pay, you can get any determination of death you want. I guess I'm so I'm a little bit challenged by this notion, and that is so for Pope Pius XII, there was a recommendation, not a recommendation, but guidance that at some point, extraordinary means, however that's defined, are not required under the circumstances. And I'm wondering if there is anything similar in Islamic thought, given the fact that you just said, there's not a lot of bedside ethicists, and there might or might not be a lot of ventilators to be able to get that support. Is there something similar to think about it in terms of, okay, let's say that we're only willing to accept cardiopulmonary death. What's our obligation to continue support under the circumstances for people who can't buy a bed in the ICU or can't buy a ventilator for home use?
Yeah. So when I often give the set up the Islamic Bioethics talk on brain death or death and dying, I start, and I did it in our conversation here over time, start with what is obligatory, right? So I think you're asking that question.
Yeah.
So from the Islamic moral tradition, and the four Sunni schools, I'll talk about the Shia school in a second, but medical healthcare seeking is not mandatory. It's not obligatory. You're not sinful for not seeking healthcare. That's the general ruling. And so the only time that it becomes morally obligatory is if there is a certain treatment, and without that certain treatment, right, you will cause your own death. You will die. So the analogy is if someone's bleeding out and they refuse to put on a tourniquet, and then that, right, you're culpable for voluntary suicide in a sense from the law perspective. And so that's the bar. We have to have a certain treatment, right? That would be certainly life-saving. Now, when you move that to the end of life care domain, it becomes complicated. You could say, hey, well, some signs of life exist at all, potentially, if we put someone on a ventilator or so on and so forth. But that the conversation switched to, well, not just the resource allocation thing. Most scholars don't talk about that, but they talk about the fact that you are now harming the body. There's a dignity to the body. Every intervention in medicine disrupts the inviolability or the sanctity of the body, right? It's a simple catheter. And those harms are not leading to any benefit, right? So that's if the life of an individual is to make for the afterlife, and that individual in that state, being sedated or whatever else it is, cannot merit make for the afterlife, and all that you're doing is accruing harms. So that's how they get out of that notion of keeping people on ventilators who might be neurologically or meet the neurological criteria for death. That said, in several Muslim countries, Saudi Arabia, Qatar, there are who have the means, there are certain wards where you have patients who would meet the criteria for neurological death, but they're continued to be supported maximally. As I said, if you're able to pay, you can have that, and you can have that in the United States as well. Obviously, catastrophic ends do happen at that point, but if you're saying I don't want to agree with brain death until the heart stops, then you can do that. So that occurs.
And just a follow-up question, because we've said, brain death, and then there's this other option of circulatory death. Do you have any thoughts about, because in general we would say, okay, the brain is the first thing to go, and then later on it'll be the heart that would go. But there are some situations in which there's sudden cardiopulmonary death, and yet the brain arguably might be able to be resuscitated for longer periods of time. Is there any pushback in Islamic thought that says, hey, now that you've opened this can of worms called brain death, maybe we have the obligation to try to resuscitate in the interim to be able to show that the brain has died? Because the used to be 3 minutes in the brain is gone, but now I think studies are showing that's not the case. So is there anything kind of challenging the thought that cardiopulmonary death is traditional death? We understand what that is, and that's the standard of death.
Yeah, so that's a very good point. And I'll tell you, I know of no writings, but there could be writings I don't know about, right? That lay out what you just said. But I will say that there's several complications that occur then if you were to take that notion. One of which would be that from the scriptural perspective, there are signs of death within the tradition, right? So and snackling of the so the signs that we think about traditionally associated with cardiopulmonary death have become our scriptural sources in some cases, according to some, right? Because the prophet and his companions looked at these for death. Others say no, they did that because it was just a custom of the time. And the weight you give to those signs is based on your notion of whether it's custom, because then custom can change, or whether it's scripturally driven. So there's a significant complication that might occur thinking about, can we discard those traditional signs or not? And then can we then engage with the conversation, well, there's an obligation to figure out whether the brain is still salvageable or not. So in any case, I think we have a very rich discussion, but I haven't seen anything written on it. So
thank you. And again, it's just it's one where as we get technologically better with resuscitation and ECMO and a number of other things, it may be something that would come up. Well, unfortunately, we have reached the end of time, and we have a comment saying excellent scholarship and presentation, Dr. Padela, from our Institute Director, Dr. John Moyer. Just a reminder to folks that we have a colleague who is going to be speaking to us next month during our Professionalism Week. It's on bioethics and medical humanities, looking at creative, and my apologies, I wanted to get it up there and I lost it. Let me see if I can try one more time. It is on it happens to fall in Professionalism Week, and it's called Professional Creativity and Perseverance in the Theater and in Medicine by actor and playwright Jonathan Gallard-Daly. Again, the information about our way to get credit is in the text. Also, information about our master's program in bioethics is in the text. Please join me in thanking Dr. Aasim Padela, and we will see you next month. Thank you so much, Aasim.
thank you. Take care.